ما يسمعش. ها؟
الو.
دكتور احمد تسمعنا؟
سامع حضرتك كويس. حضرتك سامعني؟
سمعتنا. الصورة هذه تعرفها ما اللي فيها؟
الصورة دي is very touching to me بصراحة، يعني really touching، لأن it took me back to very nice days since I met Dr. Aziz. Dr. Aziz is a very dear friend to whole Egypt, and he is a so beloved person. And really, that's a very nice present on the beginning of the talk. Thank you very much for this. Thank you, Aziz.
So we hope that we'll get benefit. دكتور أحمد ما سمعناش طبعا من البداية. He is one of the well-known international figure in the field of glaucoma, and he's a well-known pioneer worldwide. And so we are proud of him, and we hope to get benefit from Professor Ahmed Mustafa. هذه الصورة لما كنا في قسم 14 في جامعة القاهرة في قسم العيون، الدكتور أحمد معنا والدكتور أيمن والزملاء معنا احنا في جامعة القاهرة. Okay, let's start. دكتور أحمد. دكتور أحمد مصطفى. الدكتور إبراهيم الحمدي معاك يا دكتور أحمد.
اهلا يا دكتور ابراهيم، ازي حضرتك؟
هقول على حضرتك معلومه صغيره. الدكتور احمد مصطفى استاذ في جامعه القاهره، وطبعا هو الاول على الدفعه طوال ال6 سنوات، والاول على الدفعه في البكالوريوس. الدكتور احمد لما تخرج يعني كلم والده انه بده يتخصص في العيون. تذكر دكتور احمد لما والدك اعترض وقال يعني بعد 6 سنين من التعب وطول 6 سنين وفي الاخر تخصص في العين بس، حضرتك اخذته المكتبه ووريته كتب العيون، فيعني وافق بعد كده. فاكر القصه دي؟
لا، هو انا ده كان حديث مع نفسي يا دكتور ابراهيم، ان انا صعب عليا بعد هذه الرحله الشاقه ان احد الاصدقاء الاعزاء قال لي تتخصص عيون، فانا قلت له عيون يعني ازاي العيون بعد الرحله الطويله دي؟ وبعدين في الاخر انا اخذت حته صغيره في العيون وحته جوه الحته اللي في العيون كمان. ف دكتور ابراهيم، يعني انت سايبنا بذكريات جميله، كلنا بنحبك جدا جدا. وانا يعني النهارده يمكن يعني حضرتك ودكتور عزيز وكل الجمعيه فعلا يعني خبطتوا في قلبي والله، يعني في حقيقه، يعني حقيقه فكرتوني بايام جميله وخلتوني اشوف اصدقاء انا بعزهم جدا. وطبعا كل الزملاء في اليمن، دكتور محمد ودكتور محفوظ والجميع، يعني لهم في قلبي وفي قلب كل الزملاء المصريين مكانة كبيرة جدا 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 بصراحة.
دكتور أحمد شكرا جزيلا على مشاركتك بمحاضرة ديب سكليروتومي. حضرتك تبدأ إن شاء الله. شكرا جزيلا.
أنا بهنيكم على يعني على هذا النشاط المتميز في الأسبوع المتميز. I will go through deep sclerectomy. That's a subject that I spend a lot of years, like 20 years, working on deep sclerectomy. During deep sclerectomy, what we do is what we do is that we dissect a superficial scleral flap like the trabeculectomy one done by Dr. Muhammad, and then we dissect a second flap. This second flap should not open the eye, it should expose the trabecular meshwork and just few landmarks. This is the end of the sclera. This is called the scleral spur, should be visible, a sharp line. And then this is the Schwalb's line, which is the junction between the trabecular meshwork and the Descemet's membrane. The percolating tissue is here. This is the trabecular meshwork, and this is the floor of Schlemm's canal. You will see some blood coming from the cut ends of Schlemm's canal upon dissection. And what happens that the trabecular meshwork tissue is by nature is percolating so that the fluid will come and will diffuse basically to the subconjunctival space. So this is the principle of this operation. But because the eye is not opened, this is called the non-penetrating glaucoma surgery. And because we excise the deep flap, this is called deep sclerectomy. So if this is the sclera, we remove the sclera overlying the area of the Schlemm's canal in the superior part of the limbus, allowing the fluid to percolate. Deep sclerectomy is generally indicated for open-angle glaucoma. That's why gonioscopy is mandatory to make sure that this is an open-angle glaucoma. Definitely, it is almost contraindicated in patients with chronic angle closure glaucoma and patients with secondary glaucomas. So the selection of the case is very important for the success of the operation. When we look at the glaucoma management armamentarium, you know that the first lines of treatment are here, being between laser trabeculoplasty and medical treatment. And you know nowadays that laser trabeculoplasty is trying to get the lead through the light study. And then we will, if we need to operate on the patient, usually the operations of choices are either trabeculectomy or non-penetrating deep sclerectomy according to the surgeon's experience. And this is very important. We should not float between these two options. We just select one and then we spend years of work trying to improve our technique. And then if those options are not suitable, we will move to valves and cyclodestructive procedures. When we look at any operation, we think of the efficacy and safety, as you know. Once we open the eye during deep sclerectomy, the fluid will come gradually so that there is gradual reduction of the intraocular pressure. This is very important because we operate on patients with very advanced glaucoma, and you would love to avoid sudden hypotony, a sudden drop of the intraocular pressure. And that's the beauty of deep sclerectomy. It allows gradual reduction of the intraocular pressure, even without the loss of the anterior chamber, so that we can operate on patients like that with remaining small pieces of the visual field without fears of the wipeout syndromes. The other complications like the infection and the loss of the anterior chamber are extremely, extremely rare with deep sclerectomy. That's why this operation has a high safety profile. We can combine deep sclerectomy with phacoemulsification for those having cataract and glaucoma. And we can combine as well with the trabeculotomy for those having developmental glaucoma, so that we dissect the flap and to get percolation. And then we will go with the trabeculotomes through the cut-ins of Schlemm's canal to do trabeculotomy, so that we can combine also deep sclerectomy with trabeculotomy. Like here, the patient with juvenile glaucoma, we have cut the deep flap, and then we will go inside the Schlemm's canal to do the trabeculotomy. Now let us go shortly through the steps here. I'm injecting a diluted mitomycin because it's a subconjunctival filtering operation. We need to have antimetabolites. And then we spread it. The concentration is 0.04 milligram per milliliter, and we inject only 0.1 milli. So it's a diluted mitomycin. Then I like to get a generous conjunctival incision, generally speaking. I don't like to operate on small openings of the conjunctiva. I open the conjunctiva and then I extend the dissection posterior. Again, it is an external filtering operation with high safety profile. So after we dissect, and this patient is a juvenile patient, like most of our patients in our region. So there is a lot of tenon. We cut the tenon, and then we do diathermy as needed. And I like to work on a field which is a bit bloodless. And then I dissect a large superficial scleral flap. Again, a large flap, and you can even extend more posterior. This small crescent knife, if you have it, it's a very, very good an instrument for the scleral dissection, the small sized one. And then you can dissect under direct supervision until you get to the periphery of the cornea. During the dissection, you will get new bleeders so that there is still time to do a diathermy after dissection of the superficial scleral flap. Again, in those operations, we need to have good exposure of the peripheral part of the cornea because we need to expose good part of the trabecular meshwork. Now, additional diathermy is done before I dissect the second flap, because after we dissect the second flap, it's a bit not easy to do diathermy. Here, because the pupil is dilated because of the local anesthesia, so I'm doing paracentesis and injecting intracameral myotics. So it is not for gradual decompression, it is just for constricting the pupil. Now you see the surgical area, a large part of the cornea is seen, and here is the surgical area. Still, there is a place to do diathermy before dissecting the deep flap. Now we will go for deep flap dissection within the context of the superficial flap. So that it shouldn't extend beyond, just in case the operation is converted. And again, the starting point is important. You need to see the blue shine color of the ciliary body. This is very important. Don't leave too much sclera and don't cut down to the ciliary body. It will happen during the learning curve. But again, try to just leave a very, very thin layer of sclera and proceed forward in the same plane. You shouldn't do anything. It is just a deep dissection plane. And then you will end to a point. This is the end of the sclera. Again, it should be a straight line. If it is irregular, think of abnormal plane. And then this is part of the floor of the Schlemm's canal. This is the trabecular meshwork, and you can see the trabecular meshwork will percolate with time, so that if at the beginning of the operation it's not percolating, just try to remove the cells of the trabecular meshwork with a dry sponge, and you will get more and more percolation with time, as I'm doing here. And here is the beginning of the Descemet's membrane. I am too careful about exposure of the trabecular meshwork, not the Descemet's membrane itself. Then I go for dissection of the deep flap. Again, this deep flap contains the Schlemm's canal, either the roof of the Schlemm's canal or sometimes the whole Schlemm's canal. And then after you cut, you will test for the percolation. Do you have to remove more tissues or not? So again, dry sponge is important. Then are you comfortable with this level of percolation or not? Because you still can remove part of the corneal shelf here that will give more and more percolation. And here, this is the beauty of the operation. There is gradual reduction of the intraocular pressure. You are not afraid of hypotony, especially the sudden hypotony. Now I'm removing additional parts of the corneal shelf, which will remove more resistance on the trabecular meshwork and will help more percolation. So because of the excision of this sclera, this is called deep sclerectomy. Now I'm showing you again, this is one of the sutures, which I'll show just in more details right now. So this is, generally speaking, the end of the operation. Let us move forward to this patient with pigmentary glaucoma. Again, a large scleral flap. Yes, diathermy as necessary. You shouldn't scar, you shouldn't char everything. Just make sure that the field is good, and then dissecting the superficial scleral flap until the periphery of the cornea. You should have good exposure of the periphery of the cornea. This is sometimes not necessary with trap, but it's important with deep sclerectomy. Then going for dissection of the deep scleral flap. Sometimes those perforating vessels do bleed. You will do diathermy before you dissect the second flap. Again, the small crescent is very helpful. Just go in the forward, and then you will open the posterior wall of Schlemm's canal, and then you will get the percolation, and then you will cut the deep flap. And here you can see some pigments, because this is a case of pigmentary glaucoma, which needed surgery. Then you will test the percolation at this stage. Now, if it happens that you perforate the eye, there is no problem. You will convert to a trap. Again, I'm showing you an additional step, which I felt it added something to the operation in the way I'll show to you. This is the subflap matrix suture. It is just 10-0 nylon suture. You know that we need to place like a spacer underneath the superficial scleral flap to help the aqueous to accumulate. And here I introduced to the literature this simple economic maneuver of having a matrix suture. But this matrix suture, it extends beyond the dissection, beyond the flap, so that this suture will elevate, it will act as a lever and will create a space for the fluid to accumulate. And also I put the proximal limb on the trabecular meshwork. And this is the conclusion of the surgery, so that you will see the suture extending beyond the edge, elevating the flap, helping the fluid percolation. This is the subflap matrix suture. Another advantage that the suture lies in the area of trabecular meshwork. In case I need to augment my operation with suture lysis, then I'll cut from inside directly over this suture, so that this matrix suture actually added a lot to my work. And you can see the diffuse bleb after this operation. And also it added to the success. And this idea was published in the Journal of Glaucoma less than a year, and we have obtained better results compared to the standard surgery. Now, if you are interested in this suture, this is a kind of modification. Now you can see the fluid percolating after cutting the deep flap, and then I'm trying to do the suture in a different way. I just place it horizontally. Definitely, you might be afraid of injuring the surgical site. Actually, this doesn't happen because with reduction of the intraocular pressure, the membrane becomes concave. So it's not easy to injure it. And then I'm taking the suture. And why I'm doing that? Because I want to make sure that the proximal limb is lying directly over the trabecular meshwork, so that when I go for gonioscopy, I'll see the suture in case I need to make a hole in the area of the trabeculodesmit's window. So this is a kind of a modification. And again, this is the appearance of the subflap matrix suture. This limb is on the trabecular meshwork, and this limb will help in elevation of the flap and creating a space. And this is the appearance, and this is the beauty of this suture. The post-operatively, you can see the suture here, so that if you need to do a perforation here, you are all the time guided by this suture, which I think it's the biggest advantage of this subflap matrix suture. Now, if you are going to adopt deep sclerectomy in your work, you need to have good information about the post-operative care, because most of the doctors are worried that what shall I do if the pressure goes up? This is the major problem. And then this is, of course, the nice appearance that we will get. But remember that post-operatively, the pressure will go down, so that in the first post-operative week, the pressure is 5, 6, 7, which is really good. But the anterior chamber is beautifully formed. You don't have a problem with the anterior chamber. Then there is gradual elevation of the intraocular pressure, and it reaches somewhere in the teens, so that you need to know this is the natural change in the intraocular pressure, which is suitable for most of the patients. Now, if the pressure goes up, definitely exclude steroid response, especially if the patient is highly myopic. And then you will do goniopuncture. And if goniopuncture solved the problem, it's okay. If not, then you can add some few anti-glaucoma medications, or you can go for subconjunctival needling, because as I said, it is subconjunctival filtering operation with extra safety. Then if it works, good. If not, you can do revision of the surgical site, or you can do another operation. So again, you have everything now if the pressure goes up post-operatively, but the most common is to do goniopuncture. So let us see this patient, she underwent deep sclerectomy. Now, after 5 months, the pressure is 25, which looks like a slightly high intraocular pressure. Then I do gonioscopy, and then I visualize the trabeculodesmit's window, and I do a puncture with the YAG using 6 millijoules. So this is the power like in iridectomy. And this is the opening that we create after the YAG. And again, and now, if you do goniopuncture and then the pressure is still uncontrolled, so that this means the patient is having resistance in the subconjunctival space, then at that time you can do needling. So is there a place for needling after deep sclerectomy? Yes, because an external filtering operation, and you can see here, this is the ring of Sturgis Dr. Muhammad have shown and have demonstrated. And then you will go with the needle on the edge, this area, and then you will do multiple cuts until you can communicate the area of the bleb with the remaining subconjunctival space. So there is a place for needling. Then if the patient does not respond to goniopuncture and then does not respond to needling, this means that we can do something else. We can do revision. Yes, we can do revision. We can open the surgical site again. We can add anti-metabolites, and we can help the percolation again. And why the pressure goes up? Because there is gradual thickening of the trabecular meshwork and trabeculodesmit's membrane. So we can open the surgical site, we can add more anti-metabolites and make the operation working again. Now this patient underwent the operation 45 days ago, and then she came with an elevated pressure. If the pressure goes up after deep sclerectomy, please do gonioscopy, and then you will find this was the finding where there is an iris adherent to the surgical site. And this is one of the problems, that sometimes the iris moves to the surgical site, and that's why sometimes I do peripheral iridectomy here even before the operation. So if you have this picture, you will never diagnose without gonioscopy. You will take your patient to the YAG, then you will add few shots to retract the iris and open the surgical site again. And this is the case with the reformation of the bleb immediately. Now, a patient underwent goniopuncture. Just after goniopuncture, tell your patient, please don't rub your eye, because now it's converted from a non-penetrating to like minimal penetrating operation. If the patient rubs his eye, he can get the iris like that. You'll find the pupil peaked, and then the iris is incarcerated at the surgical site, even after goniopuncture. And again, we can use few spots of YAG just to retract this iris and regularize the pupil once more, and then allow the surgery to refunction. Again, after deep sclerectomy, ask your patient that it is just a lifelong risk, that don't rub your eye, don't traumatize your eye. Again, this is a warning after all glaucoma operations, especially after non-penetrating surgery, because they can prolapse the iris through a ruptured surgical site that could happen like in this patient. So again, if the pressure goes up, please do gonioscopy and manage accordingly. And here you can see the suture beautifully placed. If you need to do goniopuncture, please cut on this suture. This will help you a lot in doing goniopuncture. Sometimes we cannot identify the surgical site, but if you have the suture, you will cut directly over it like here. So the take-home message is that deep sclerectomy, it's an external filtering operation which is showing greater safety, and it is suitable again for all ages, so that for the aged people, for the juvenile cases, and for the children, especially if you combine with trabeculotomy. And again, it's suitable for all stages. It is an operation even for far advanced glaucoma, even shows greater safety in those cases. The post-operative care is crucial, and the subflap matrix suture actually is a valuable add in my practice. And this is just my email in case you need to have any concern. And with that, I thank you very, very much.
شكرا جزيلا استاذنا الدكتور احمد مصطفى. ان شاء الله 4-5 اسئله بل كثير ان شاء الله. اكيد الدكتور عصام. دكتور احمد شكرا ان احنا شفتك معك دكتور عصام. يا دكتور احمد ان شاء الله تكون فاكرني.
طبعا اهلا وسهلا. اهلا دكتور
انا
عصام.
سعيد اني شفت حضرتك والله العظيم، وانت لسه ما تغيرتش، يعني زي ما انت زي ما سبتك.
الله يخليك، اشكر حضرتك، شكرا جزيلا.
انا سعيد اني اشوفك النهارده.
الف شكر.
طبعا الدكتور احمد والله غني عن التعريف، واحنا يعني معانا مكسب كبير ان الدكتور احمد يشاركنا في المؤتمر النهارده، لانه من البايونير في الجلوكوما سيرجري. وزي ما انتم عارفين ان البنتريتنج جلوكوما سيرجري هذا مش اي حد بيعملها، مش في اليمن، هناك في مصر، ومن الناس النادرين اللي بيعملوا لنا البنتريتنج جلوكوما. عمليه مش سهله، وعاوزين نستفيد من حضرتك يا دكتور احمد. التارجت انتراكولار بريشر، احنا يعني صح احنا بنخاف من الفول تكنس ترابيكلوكتومي، بس التنشن بيظل هاي ولسه مش مناسب للاوبتيك نيرف. ففي النون بتريكس انت بتخفض الضغط، بس لسه ما حافظتناش على الاوبتيك نيرف. التنشن ستيل هاي فور ذا اوبتيك نيرف. ايه راي حضرتك؟
ناو زي ما قلت لحضرتك دكتور عصام، ربنا يكرم حضرتك يا رب. هو في البريشر في كيرف معين، ان البريشر في اول اسبوع بيبقى low and then there is gradual elevation of the pressure، وقد يوصل للتينز، واحيانا بيعدي التينز كمان، تلاقيه 21 22. At this point انت محتاج to decide هل do you need to augment your operation with goniopuncture ولا لا. Sometimes you don't need at all and sometimes you need. لما نيجي نفكر احنا عايزين نوصل بالبيشنت قد ايه من الانتراوكلر بريشر، ديفينتلي ده بيعتمد على الستيج اوف ذا ديزيز. انا متفاهم ان حضرتك بتفكر اكتر في الناس اللي في advanced cases، لانه لو البريشر 14 15 16 ده suitable for most of the patients، ولكن انت حضرتك بتفكر اكتر في الناس اللي هم advanced. عايز اقول لحضرتك ان الادفانسد جلوكوما intervention study generally speaking لقيت ان الناس اللي عندهم that an intraocular pressure that is 18 or less usually they do not progress usually despite that the recommendations is to go for a lower intraocular pressure. The point يا دكتور عصام ان انت you have weapons to do so that you can do goniopuncture, you can reach the target pressure at the end of the day provided you focus on the operation. The point, you cannot float between trap and deep sclerectomy, just work on it and you will get the best out of it.
معلش اخذ من حضرتك حاجه ثانيه دكتور مصطفى.
عينيا.
الاوكيلر مساج اللي بتقول حضرتك انه هو مش ادفوكيتد. احنا عاده الاوكيلر مساج احنا بنستخدمه كثير في الجلوكوما فلترنج سيرجري في البوست سكند والثيرد داي علشان لو في بلوكج احنا ما فيش حاجه بتفكها الا الاوكيلر مساج.
يس.
حضرتك ايه راي حضرتك في الكلام ده؟
شوف اقول لحضرتك حاجه، طبعا ايه الفير من الاوكيولر مساج هنا ان احنا ما عندناش ايريدكتومي. مع الترابيكيلكتومي انت عندك ايريدكتومي فما عندكش تشانس اوف ايريس برولابس. الاوكيولر مساج هنا ريسكي انه لو احنا رفعنا البريشر مره واحده ممكن we induce rupture of the trabeculodesmate window and the iris will prolapse، وبالتالي ده احنا عشان كده we warn البيشنت ان هم ما يعملش مساج. ولكن one of the observations اللي مرت بيا اثناء واحده من الستاديز ان كان التريتنج دكتور بيعمل some kind of massage to the patients and is obtaining a lower pressure, but it's done by a medical doctor. And I think the point for the patients, the patient should never do massage. For the doctors, I think the point يمكن تحتاج further studies ان احنا نوصل لconclusion فيها باذن الله يا دكتور عصام.
دكتور احمد، اخر سؤال ان شاء الله قبل ما نعمل كونكلوجن للليكتشر. الليرنينج كيرف اوف ديب سكليروتومي بالنسبه للبيجنر وبالنسبه للي اكسبيرينسد كان في الترابيكيلكتومي ويبتدي يشتغل ديب سكليروتومي قد ايه؟
يعني خليني اقول لحضرتك ان اي بروسيدور انت هتفضل طول حياتك فيها في ليرنينج كيرف، وانت هتجيلك الكومبليكيشنز اكتر فتره هتجيلك فيها كومبليكيشنز لما تفيل كونفيدنت، مش في بداية حياتك. انت في بداية حياتك بتبقى كوشس جدا وشغال كده وورد ويو كونسلت وبتاخد ناس، انما لو في لحظة الواحد جاله سنس ان هو يعني متمكن، هي دي اللحظة اللي هيجيله فيها complications. The beauty about deep sclerectomy ان هو احنا اكتر حاجه ممكن تضايقنا انترا اوبراتيف ان يجي لنا perforation، يعني we injure the trabeculodesmate membrane ونتحول للترابيكيلكتومي. I think دي ممكن تبقى frustrating شويه، ولكن the beauty ان في some studies بتقول ان احنا even لو if you convert it to trap and then we will just close the flap tightly to make sure in filtration is not in excess, and then the complications are not even greater than compared to trabeculectomy. وبالتالي الناس اللي هي بتبدا اللي they need to move to deep sclerectomy هم بيعملوا trabeculectomy, they will go gradually for deep sclerectomy, and then if the case perforated at any time, I mean the macro perforation where there is an iris prolapse, it is just converted to trap ويتعاملوا معاها كده until ان هم يبقوا متمكنين من ال dissection of the deep flap. But انا في رايي حقيقه ان ال learning curve مش عظيم قوي زي الناس خايفه منه بصراحه، يعني الناس بتبقى مقلقه منه، من I think it is doable جدا 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 provided انك الواحد يركز فيه.
شكرا جزيلا دكتور احمد مصطفى، ونشكرك على مشاركتك معنا في المؤتمر. بارك الله فيك، شكرا جزيلا.
الله الف شكر، بالتوفيق، شكرا جزيلا، مع الف سلامه.
دكتور احمد.
شكرا يا دكتور عزيز، والله اسعدتني النهارده، والله يعني عارف فعلا يو تاتشد مي والله جدا جدا جدا. الف شكر، الف شكر.
شكرا جزيلا، تسلم.
الف شكر، الف شكر، مع السلامه.
Thank you very much.